All right. There, can you see me?
Yes.
Great. Thank you. Thanks for having me, and thanks to all that are attending. So it's my pleasure to get to talk to you today about the healthcare worker guidelines. The title is New Healthcare Worker Guidelines. I'm going to have to remove that soon. They were published in 2019, so they're not quite as new, but we're going to go through what was in that update and some scenarios that may be helpful related to kind of some common questions that we got. So I don't have any disclosures. I did want to acknowledge that Dr. Lynn Sosa, who was the co-chair with me for developing this update, had shared some slides with me that I adapted and will be presenting in this talk. As far as an outline, I'm going to go through a little bit of the background and rationale about why we went through the process of updating the guidelines, review with you what has changed and what stayed the same, and then touch on some scenarios that I think address common questions that we had received. And lastly, in one of those scenarios, we're going to go over a little bit the issue of TB testing and timing related to the mRNA COVID-19 vaccines. So most or all of you may be familiar with this document published in 2005 and was the guidelines for preventing transmission of TB in healthcare settings. And this is a fairly extensive document covering lots of different aspects of TB prevention within healthcare settings, including the screening and testing of healthcare workers. And so just looking at a summary of the recommendations from that document, the guideline said, well, you should do an evaluation at hire, so symptom screening and either an interferon gamma release assay or tuberculin skin test in those without a prior history of TB or LTBI. That should be repeated after exposure in people who were previously negative. And then serial screening and testing was recommended for healthcare personnel in what was termed medium risk settings or settings with potential for ongoing transmission. And then lastly, there was a recommendation regarding follow-up of people who tested positive, and the recommendation was to refer them for treatment and to do annual symptom reviews. So one of the things that prompted the sort of reevaluation of the testing recommendations for healthcare personnel was the shortage of Aplasol in 2013, and the recognition that a big area where these tests were being used was in healthcare institutions doing regular testing of employees and volunteers and other personnel. And the sort of strain that was placed on that by the national shortage. So in 2015, there was a joint session at the National TB Conference between the two groups, the clinicians group, NSTC, and the nurses group, NTNC, talking about this issue of regular testing of healthcare workers. And from that, there was a working group created. That working group met periodically for a couple of years, and then in 2017 really had established a plan for how to approach this topic through a systematic review, and the systematic review was started. And there were several research questions that we were looking to try to answer and use the literature, published literature, to see what was out there. So we were looking at what is the prevalence and incidence of LTBI among healthcare personnel in the U.S. What is the incidence of TB disease in that group? Does annual or serial testing with either a skin test or an IGRA reduce the risk of TB transmission in healthcare settings? Does annual testing increase the detection of occult TB transmission, so otherwise unrecognized transmission in healthcare settings? And then are certain individuals within healthcare facilities at higher risk than others based on either occupational or non-occupational factors. So we had to choose a methodology, and there are several different ways to do a systematic review. And for the topic and the types of literature that was going to be available, we chose something called the Community Guide for Systematic Reviews. For all of the studies that met the inclusion criteria from the initial searches, there were 2 reviewers who independently screened and abstracted the data for each. And then if there were any disagreements between the 2 reviewers, then the larger group of working group members would resolve that disagreement by consensus. And so this is what it looked like. We started with a search from January of 06 that went through February of 2017. And then as we got sort of closer to really working to have a final document to submit for peer review, we did an additional search, so that covered February through November of 2017. And the numbers are not important. It shows sort of kind of how and where things were removed, but essentially out of what, a broad search that started out with over 1,100 articles just based on some key search terms. When we filtered down, there were 36 total publications that were included in our meta-analysis of this. So what did we find from all of this? We found a number of things. One, that there's a relatively low proportion of U.S. healthcare personnel who test positive for tuberculosis infection at baseline. Less than 1% of U.S. healthcare personnel is previously negative converted to positive test results during serial testing. Nearly half of the healthcare personnel previously testing positive reverted to a negative test if retested. So if they were those who had a positive either by skin test or by an interferon gamma release assay, if they underwent another test, even in the absence of treatment, half of those would be negative on simply with a retest. And there really was insufficient evidence to assess the incidence and transmission of TB among healthcare personnel. In one large study, there were no cases of TB disease among about 64,000 U.S. healthcare personnel who were included. So what does this all mean? Well, in part, it means that when we looked at this, not unlike other previous versions of the recommendations, the published literature is thin and somewhat lacking to be able to answer these questions. So a lot of what is in the updated guidelines was based on expert opinion, extrapolating from the data that did exist. And so with that, we were able to get a very narrow update to that 2005 guideline that was focused solely on the screening, testing, and treatment of U.S. healthcare personnel. And so you can see the reference there in the MMWR, and I included in the slides the web link for folks who want to find it. It's also included in your downloads along with a companion document. And this is the group that was involved in developing these. One of the keys that Dr. Sosa and I really wanted to try and seek from the beginning was a sort of broad partnership in developing this that included members of the Division of TB Elimination at the CDC, other key CDC partners. So there were representatives from both NIOSH and DHQP, so other divisions that have important roles in workplace safety, and then lots of representatives from different areas in occupational medicine, and so we found that it's extremely helpful to have broad perspectives represented in the work group. A couple of things that were different that had to do with definitions. And so one was and you may have noticed this already, that healthcare personnel, or HCP, was used to replace healthcare worker. And this was done to be consistent with what the current HHS and CDC preferred language was. Had to do with the concept that worker implies someone who is paid and doesn't necessarily, isn't inclusive of volunteers and students or trainees and things like that. So personnel replaced worker. But the definition actually was unchanged. If you look at the definition from the 2005 recommendations, even though the terminology was healthcare worker, it included all of those groups: laboratorians and volunteers and the rest. We wanted to specifically define TB screening and differentiate that from TB testing, because those two terms get interchanged at times, and if you read through the 2005 document, there's some mixing of terms at times, and so we wanted to be clear about what we were talking about. And so TB screening we defined as really the broad process that includes a risk assessment, symptom evaluation, and a test if indicated, if no prior positive for TB infection, and that could be either a skin test or the blood test, and then additional workup for TB disease if indicated based on that evaluation. So that's TB screening, whereas TB testing is really the performance of either the blood test, the interferon gamma release assay, one of those, quantiferon or T-spot, or a tuberculin skin test. Some key changes in the new recommendations. One was that with the pre-placement testing, along with the symptom assessment, we included a recommendation to do an individual TB risk assessment. The reason this was added, and the reason we think that it is really important, is that you need to understand what the individual's risk is to interpret the test that you're doing. And so with the tuberculin skin test, we know that there are different cutoffs depending upon an individual's risk of TB exposure and risk of reactivation. With the interferon gamma release assays, it's been recognized that in otherwise low-risk people, and that includes nearly everyone who is working in healthcare in the U.S., if you get a positive by one of those blood tests, the guidelines recommend doing a second confirmatory test, because oftentimes that initial positive will be a false positive that is discovered when you do it, when you either repeat the same test or do a different test to try to confirm it. So that was new. Post-exposure didn't change at all. So if there's a known exposure in a healthcare setting where TB wasn't suspected, and so proper precautions weren't taken, and with regard to masking and negative pressure rooms, then there should be an evaluation of anyone that was exposed. The biggest change was probably the recommendation around serial screening and testing, and the change was that doing that serial screening testing was no longer routinely recommended, with the caveat that we left in it can be considered in certain groups. And the reason we left that in is because we recognized through many conversations with our occupational health colleagues that we weren't going to be able to predict all the different scenarios that might come up for an individual institution where they may have select groups who are at higher risks, and the institution feels really should undergo continual testing. And so we left that as the flexibility, important flexibility for the people doing the work to actually decide what makes sense for them. We did recommend, not a new recommendation, but perhaps a new emphasis on the importance of annual TB education of all healthcare personnel, including their TB exposure risk, because the exposure risk is largely not from healthcare work in the U.S., but it's from other activities. If people volunteer or work outside the U.S. in settings where TB is more common, then getting retested upon return, and typically waiting 8 to 10 weeks after returning from a setting like that to get retested makes sense. But those are also things that organizations don't always know, can't predict, and something I learned through this process is they're not even allowed to ask all the time about non-work related things like travel. So occupational health providers aren't going to know that, but it's important that the individuals know that, so that if they do have a potential risk for exposure, that they could and should get retested afterwards. And then the follow-up recommendations. It's kind of new, kind of not. We really emphasized and strengthened it a bit from what was in the 2005, saying that really treatment should be strongly recommended, not just they should be referred to someone else, but that occupational health should have a role in strongly recommending treatment of healthcare personnel who have latent TB infection. That largely when there are examples that show up in the media and elsewhere of exposures happening in healthcare settings, oftentimes it's from healthcare personnel who were known to have latent TB and didn't take treatment and then reactivated later. So really, unless there's a contraindication, a real contraindication to treatment, everyone should be strongly encouraged to take it. So just going through some of these in a little more detail. So the baseline or pre-placement screening and testing, again, it should include this individual risk assessment, symptom evaluation, and then one of the tests. It's not recommended to do both. And then if you have low-risk healthcare personnel who test positive, they should have a second test. And that's really comes from and is consistent with the TB diagnostic guidelines that were published in CID in 2017 that say the same thing. As far as a baseline individual risk assessment, we did include an example of this and how it might go. Again, one of the things that the occupational health providers shared with us is that they are limited in what they can ask of employees in terms of health risks and outside travel and other things. And so we tried to make it simple for them, and in such a way that it doesn't compromise the individual having to give up information that they may not be comfortable sharing. So it really we based it also in part on the risk assessment developed by the California state TB program, and so it looks at where have people lived. And if they've lived in an area where TB is common, it would ask if people currently are likely to have immunosuppression and the risk associated with that in terms of progression, and if they've had known close contact to someone with infectious TB. Again, all of these are important things in terms of interpreting a test, so particularly if you're using the skin test, because the cutoffs are generally different depending upon if the answer to these questions is yes or not. And then the post-exposure screening and testing. And so this is, again, didn't change. So if there's known exposure without personal protection, and that's the key. The key is without personal protection, because most brief interactions with someone are not going to reach a threshold to really be a risk. But if someone was TB was not suspected, a person was not put in a isolation, negative pressure isolation setting, and there were healthcare people taking care of them without appropriate masks, then those risks do occur at times. And then if you've got someone who has no history of a positive test, you do the symptom assessment, a TB test, and then ensure that there's a second test if the first one's negative 8 to 10 weeks later. And then first, people who were previously positive, then then symptom assessment and no retest is generally recommended or needed. So the serial testing, as I mentioned, this is where the biggest change is say that healthcare personnel really don't need to be routinely retested at any interval if there's no known exposure or no known ongoing transmission within that facility. Healthcare facilities can choose to do it on specific groups of healthcare personnel, but we really emphasize that most healthcare facilities don't need to do this, and so the decision should be individualized and should be made in consultation with sort of state and local health departments, understanding, the local epidemiology. For most, the risk is actually not occupational; it's non-occupational risk, as I already mentioned, and so these are things that institutions, as I said, can't routinely ask about legally, and they're not allowed to ask about things that that people may be doing outside of work. And so we tried to emphasize the importance of educating people annually, including about what are risk factors for getting exposed to TB, so that people are aware that if they are doing things, volunteer or otherwise, or travel that might put them at risk, then it's important for them to know. It's important for their employer or where they're working, but also very important for them. In terms of following up a positive test, if anyone tests positive, they need to get a chest X-ray. Should definitely have a symptom assessment, and then additional evaluation depends upon those findings. So if there's anything abnormal on the chest X-ray, or if the person has symptoms that are concerning, including swollen lymph nodes, unexplained fever, night sweats, weight loss, those sorts of things, then more testing obviously is needed. And then all healthcare personnel with latent TB infection should be offered and encouraged to complete treatment, and unless there's a contraindication, or obviously if they've already taken treatment, then there may not be an indication for retreatment. So this is kind of small and not meant to be read necessarily, but just to point out there is a table within the guidelines where we outline all of these things and try to show what was the language in the 2005 recommendation, what is it in the new recommendation, and whether or not it was either unchanged or new. And so you can sort of see those summarized in the document there. Importantly, one of the things that I think became obvious from the working group was that what we could say and include and publish in MMWR was going to be relatively limited, based just on the requirements for clearance through CDC and the length and other things. We weren't going to be able to put everything into that document that would be potentially helpful for people trying to implement these new recommendations. And so a separate working group made up of many of the same people that were on the guideline working group, but with the addition of some others, worked on and put together a guidance statement that was a joint effort between the American College of Occupational and Environmental Medicine and the National TB Controllers Association. And this document was just published in July of last year. Unfortunately, I'm expecting most or all of you were doing what I was doing, and many others, and most others, in July of last year, which was not thinking about TB screening healthcare workers, but responding to COVID pandemic. And so this didn't necessarily get the attention or the launch that I think we had originally hoped for. So I'm glad for the opportunity to promote it now. This I think is a really helpful companion, to thinking through the challenges that occupational health and facilities face in really trying to implement the recommendation. So with that, I want to go through some scenarios, and with this, I'm going to have some questions, and so for the questions, I guess, to answer them, I'll ask that you put your answers in the chat, and we'll probably give you 30 seconds or a little longer to think through your answer. But the first one is a primary care clinic located near the U.S.-Mexico border and providing care for binational patients calls you and asks if they should continue doing annual TB testing for their healthcare staff. And the question is, what would you recommend? And your choices, would you say yes, they should because the population they care for is at higher risk for TB? No, annual testing is no longer recommended. They should focus their resources on ensuring latent TB treatment is completed. Or maybe, I'm not quite sure, I need more information. So I'll give you 30 seconds to think about that and go ahead and put your answers. All right. You guys are doing great. I saw one question that said, can I repost it? And it's just, repost the scenario. It's, I can go back a slide and show you. So a primary care clinic near the U.S.-Mexico border caring for binational patients, and should they continue doing annual TB testing? So I saw a lot of threes, that maybe I need more information. A fair number of people said yes because the population is at higher risk, and I'd say the fewest number of responses were for number 2, no. So let me kind of go through this. So when you think about, well, what additional information might be helpful, you say, well, is it important to know the TB incidence in the jurisdiction? Does it matter exactly where it's located or not? That it's near the U.S.-Mexico border, but do you need to know more specifics or not? What if healthcare personnel had to be tested as part of a contact investigation the previous year? That would be something that would be important to know. And there are certainly other questions that we could think about that you might want to ask about this clinic. But the truth is that the population that is being served is not the primary risk. It's focusing really on have there been any evidence that there's been TB transmission within that clinic in the past based on the annual testing they've been doing. And if the answer to that is no, then really the recommendation is focus on treating people who are working there or volunteering or otherwise, the healthcare personnel who have LTBI, and really probably the greatest protection for people working there are going to be the administrative and environmental controls. So making sure that everyone is trained on recognizing what the risks and symptoms are for TB, making sure that the air handling system and other procedures for what to do if someone presents with a cough, those are the factors that are going to continue to protect people from unrecognized TB transmission. So the additional information may help frame the discussion, but it's really unlikely that annual testing in these settings has been detecting unrecognized TB transmission. And in fact, we know that most of the variability with annual testing is variability with the tests themselves. The skin test, it turns out, is pretty good at being consistent. Like if you're negative and you don't have a true known exposure, you're pretty much going to stay negative. It does happen less than 1% of the time, and it was seen in this study that Susan Dorman was the first author on, published in 2013, that compared the skin tests to quantiferon and T-spot, doing it at 4 time points, baseline, 6, 12, and 18 months. And there were some people who who converted by the skin test and not by any other, and then got a repeat skin test, and 90% of them who got a repeat skin test were negative on the repeat skin test. So I know that the old adage is if someone's positive, don't repeat the skin test because they're always going to be positive, or they might have a severe reaction. And the reality is that not everyone will have a worsened or persistent positive reaction. More importantly, before we had blood tests, if we repeated a skin test and got a different answer, we didn't know what to do with it. And so if someone was positive and they had risk, yeah, they would likely still be positive. But if they were positive and really didn't have risk for TB exposure, it turns out they weren't always positive. So, if a facility or an area within the facility has consistently seen a high rate of annual conversions, then the focus should be rather than continuing to do the testing, figuring out what are the administrative or environmental controls that are contributing to that high rate of annual conversions. And if a clinic has seen that, if they've seen a high rate of conversions while trying to figure out what the cause is and fixing it, then it would be appropriate to continue annual testing. But again, if they haven't seen it, and most places have been testing annually for extended periods of time, decades for most, and if they haven't seen that kind of high rates of annual conversions, then there's not a reason to continue doing testing. All right, next scenario, an occupational health provider calls and asks, what are they supposed to do with the new individual risk assessment, and can they stop doing the facility risk assessment that was part of the 2005 guidelines? So I apologize, these are a little longer in terms of the answer, but I'll give you extra time. So the individual risk assessment is the only evaluation now recommended. The individual risk assessment is important for interpreting TB tests, but the facility risk assessment is important for determining environmental controls. The individual risk assessment is optional and may be helpful. Facility risk assessment is still important to decide who should get an annual TB test. Or lastly, both the individual and facility risk assessment are important and should be performed every year. I'll give you about 30 seconds. Go back. I think someone wanted to see the question or the scenario again. So this is again occupational health asking what to do with the individual risk assessment. Can they stop doing the facility risk assessment? So again, just eyeing this as they come in, I've seen lots of votes for 4 and a fair number of votes for 2, and maybe a handful of 1. And I don't know if I saw any votes come in for option 3. So what to do with that individual risk assessment? So the individual risk assessment was added and is important. As I said before, because you need it to interpret the tests, right? If you don't know anything about the individual's risk and you're doing a skin test, you don't know what cutoff you should use, and if you're doing the blood test and it turns out positive, you don't know if you should believe that positive, or if as the testing guidelines would say, you should do a confirmatory test. So that's the purpose of doing that individual risk assessment. The facility risk assessment is important for determining the environmental and administrative controls that are needed, and a modified version of this was coming and is addressed in part in the companion document. And so really the best answer for this question is 2. So both are important. The individual risk assessment is not needed annually, and that wasn't part of the updated recommendations. The recommendations are to do an individual risk assessment at baseline only. and not to repeat that annually. But again, the facility risk assessment is still important to do. The facility risk assessment is no longer used to determine if a facility needs to continue doing annual testing. So it's no longer categorizing an institution as medium risk or higher, and then being the data that drives annual testing. So the next example, next scenario, so a friend calls you up who's a pulmonologist at a local hospital, and she asks if she should continue to get an annual TB test because she regularly does bronchoscopies. So what would you recommend about annual TB testing for a pulmonologist? Yes, she should get it because she does high-risk procedures. No, routine testing isn't recommended. Or maybe I need more information. Great. This one's all. The answers are a lot shorter than in that last question, so it's a little bit easier. And this is, I think, we've got the most variability in terms of what people are thinking. So I saw a good mix of ones, twos, and threes. So this is the area that I mentioned where we intentionally built in some flexibility, and so we're vague about it. And we're vague about it because we couldn't predict every possible risk scenario. And so, an argument and a case could easily be made for any of these. I think that, again, importantly, what we wanted to emphasize is almost no healthcare personnel are at risk for unrecognized TB transmission from working in healthcare in the U.S. And that's true even of pulmonologists and respiratory therapists. Now, are there potentially scenarios depending upon the community where they work in and the incidence of tuberculosis and the population where they may be at higher risk? Absolutely, and we certainly did not expect that we would be able to predict everything where everyone is working, and so this is where it makes sense for institutions to look at their own experiences. We strongly encourage talking to the local and state health departments to help in those decisions. But really, we feel like the question is not why shouldn't I test people annually, but really think hard about why should you? What is the compelling reason that any certain group is at such increased risk? And then if they are thinking through, well, what can be done to increase or to decrease that risk through the use of those administrative and environmental controls to make sure that people are taking proper protections. I see in the chat, using PPE correctly, and so that really is what we think should be the right answer. If you've got a group of people that you think are at increased risk, well, how do you decrease their risk? Because serially testing them isn't decreasing the risk. It's just saying we know they're at risk. We think they're at risk of exposing themselves to TB, but not figuring it out because they're not sending the tests for TB, and therefore the only way we're going to detect this is by using one of our tests, either the skin test or the blood test. So, places where it could be challenging and we say, gosh, these are groups that maybe would make sense to think about it, pulmonologists, respiratory therapists, coroner. It turns out coroners and others who assist in performing autopsies, transmission has been demonstrated there when TB wasn't considered as a potential cause of death. And then, potentially people working in skilled nursing facilities, if they're working with patients who have advanced dementia, that population, that group of patients, develops respiratory illnesses quite regularly. It's incredibly hard to get specimens from them to do tests for tuberculosis. And so you could think about, whether continuing to test in that sort of setting, and if it was a skilled nursing facility that cared for patients that maybe were at higher risk for having TB or TB exposure in their past, then again, those are just some examples to think about. But none of them were areas where we said absolutely these are groups that should continue annual testing. So we really strongly recommend stop unnecessary testing, treat people with known LTBI, and make sure people know the signs and symptoms of TB so that both healthcare personnel can recognize it early in their patients, in their coworkers, and even in themselves. So last scenario for all of you is an occupational health provider called to ask what to do about TB screening for a traveling nurse who received his first COVID-19 vaccine 1 week ago. He reports multiple prior negative skin tests and has documentation of a negative interferon gamma release assay 2 years ago. So in that scenario, what would you recommend for TB testing of this traveling nurse? So test for TB now, do a TB test now and accept the results. Delay TB testing until after a second COVID vaccine. Test now and if negative, repeat it in a month. Or no further testing is needed if asymptomatic and no known TB exposure. I'll go back again real quick for anyone who wants to see it. So this is COVID vaccine a week ago and is now coming to an institution, and they're doing onboarding and trying to figure out about timing of a TB test. All right. Well, I think I saw a whole bunch of 4s early on, and then a number of people voting for 2, and a mix of some 3. So without having the exact numbers, I think 4 was probably the highest, 2 was maybe second, and then a mix of people voted for 3s. I don't know if I saw anyone vote for the first option of test now and just accept the results. So you may have seen that the CDC put out a Dear Colleague letter on this topic on January 7th of this year. And I just took a screenshot of a specific part of this where they're commenting on healthcare personnel and onboarding. And so they also include in here that there's no reason to think that a TB test would affect the COVID vaccine efficacy, which I guess that's important that they put that in there. I'm not sure why anyone would have necessarily thought it would, but okay. So they emphasize, yes, you should definitely perform TB symptom screening on all healthcare personnel and patients, and I would add an individual risk assessment to that as well. They recommend if using the blood test, draw the blood prior to the vaccine. If placing a skin test, place it prior to the vaccine. But if the vaccine has already occurred, then they say to defer the skin test or IgRA until 4 weeks after completion of the 2-dose COVID mRNA vaccination. Well, I'm going to go through the options for this and give you my thoughts on it. Step 1, I think absolutely, it should be the symptom review, but also the risk assessment. So finding out what's the individual's, understanding the individual's risk for TB. So again, I didn't see anyone opting for option 1, but I think arguably you could test for TB now and accept the results. This recognizes that, in fact, there's no evidence that mRNA vaccines affect TB results. The really the theory has to do with live virus vaccines, and so and the impact live virus vaccines may have on a short-term decrease in someone's immune response to other things, and delaying related to that. The truth is, there's not a lot of evidence for the live virus vaccines either, and my understanding is that for overseas immigrant applicants and refugees, they really don't pay attention to the timing of it because it's just too complicated to try to do. So they do this. They do the test when they do the test, and they accept the results as what they are if they're testing, and they don't bother with trying to mess around with timing. And certainly this would be the most feasible from an OC health standpoint, to just do it as you routinely would when onboarding. Delay the TB test until after the second COVID-19 vaccine, so answer 2. This is consistent with what the CDC put out in their Dear Colleague letter. The problem with it is it may be very hard to implement. There just aren't systems in place to track where people are, when did they get their second vaccine, and are we enough time after that vaccine to now get them back to do their TB test. And so while it's a conservative approach relative to the live virus vaccine recommendations, actually putting it into practice could be extremely difficult. Similarly, testing now and if negative, repeating a month after the second dose is going to be a really difficult thing to do. I think you could argue it's reasonable, particularly if this person had the potential for TB exposure since the last time they were tested, because working outside of the U.S. or working in an area where TB is common, then that type of an approach is arguably the most conservative and makes some sense. But really following the updated guidelines, we would say no further testing is needed if he's asymptomatic and there's not been known TB exposure. And so that's, that option 4 would be consistent with the updated guidelines. And so again, a case could be made for any of these answers. I think, I would, strongly encourage in the setting, and as I said in the scenario, there was a documented negative interferon gamma release assay 2 years ago and a self-report of multiple negative skin tests and no known exposure. That I would argue that person can be onboarded without needing a new TB test. And I think if an occupational provider or a facility were uncomfortable with that, then I think option 1 of testing them now and accepting results is probably the next best option when you think about feasibility. And the option 2 and option 3 are more conservative, but I would suspect difficult or impossible for many facilities to actually implement. So last couple slides just to summarize. Along with baseline testing is that individual risk assessment, and really encouraging and not just encouraging, but putting in place structures that facilitate getting healthcare personnel who have latent TB infection to complete a course of treatment. So trying to make it as easy for people to say yes and to take treatment as possible, and then educating all staff to recognize symptoms and risks. And when we talk risks for them, it's the potential non-occupational exposures are the greatest risks, most likely. Also important to note, these guidelines do not override any local or state requirements. So that was a question that came up often as we were developing this. Well, my state or my local government requires these things. Does this supersede those? And the answer is no. These guidelines don't. But one of the hopes is that these could be used as a tool to help places update and change any requirements that don't make sense anymore based on the epidemiology of TB in the U.S. The guidance statement, the ACO that was published, ACO ACOEM and NTCA guidance statement is a useful tool. And then with the new COVID vaccination, it presents some challenges, but I would just strongly recommend people look for practical solutions and decision making, and not try to overthink the COVID vaccine issue too deeply, because it's not like. Truth is, it's not likely to make an important difference in terms of TB testing. So with that, we'll go to questions, and I know there have been some in the chat already about the two-step TB testing question, and is two-step testing necessary? And I'll tell you, the occupational health perspective on this has been that it is really important for them to know at baseline if someone has TB infection or not before beginning work. And with the skin tests, we know that someone who was infected, long before their test, the immune reactivity can decrease, and so that first test could be negative. Now, the obvious argument is, well, if you're not serially testing them, then who cares? And I think it's more the possibility that if there were an exposure and a contact investigation in that setting, then again, you would want to know that a second test was not causing a boosted reaction, but was you had excluded that at baseline, and so it's still, there's nothing about that in the update. We didn't talk about which tests should people choose or anything about two-step testing, but I can say that that's the Occ Health perspective on this has been, if you're going to use the skin test as your baseline test, that you should continue to do a two-step for it. And so the next question I see is discussing recommendations for someone receiving two different results from two different IGRA tests. So T-spot and quantiferon TB gold. So it's a great question. It has, it really gets down to the fact that what we have are very imperfect tests still, and so we don't have, none of these tests are good enough, independent of knowing anything about the individual, to say definitively does this person have TB infection or not. And so looking carefully at why were they tested in the first place, and what is their real risk, needs to go into making the decision about whether to do a second confirmatory test. And if you're going to do it, do it because you're going to use it to help your decision making. If someone gets tested and they're positive, and you're concerned because they're going to be starting immunosuppressive therapy, and you really are worried you don't want to miss something, don't do another test that, if it's negative, it's only going to create anxiety and it's not going to help you make a medical decision. If you say, I don't believe this person has TB infection and I don't want to put them at risk by giving them medications that they don't need, I'm going to do a test, and if that test is negative, I'm going to say, this is a person at low risk for TB infection, regardless of if they're going to be going on immunosuppressive therapy. If they're low risk for TB infection, you can't reactivate what you don't have. And so if you don't have TB infection, it doesn't matter that you're going on a medication that affects the immune system. Let's see. Next question was, discuss the recommendation for someone, no, I think I did that. TST must be used rather than IGRA. What is the thinking of positive results in a person who received BCG many years ago? So we've seen in a number of studies of this that while we know that most people who get BCG vaccine will not react to a skin test, within a couple of years or so. So BCG is generally given shortly after birth or in young children. There are still some countries that give serial BCG vaccines, and there's an online tool for finding out which countries do that. But most people will be negative by skin test, so that's why we've continued to use skin test, and why pre-IGRA and even post, it's still been a useful tool. That said, there are a percentage of people who remain positive and remain positive for extended period of times of their life, and so I can tell you, my own institution here at Denver Health has continued to use the skin test as its preferred test up until very recently. And if we had a positive by skin test in someone with a BCG vaccine, we would do a confirmatory IGRA. And so, that was a practical way to contain costs, because the costs of the IGRA, just the laboratory costs of that are higher than the skin test. You get into personnel time away from work and other soft costs that you can argue that the IGRAs are cheaper, but in terms of if you have to pay for the syringe and needles and the tuberculin, or you have to pay for the IGRA test, the IGRAs are going to be more out-of-pocket costs in that way. So that's what we do. That's what I recommend, that if someone has a positive skin test and prior BCG, I do a confirmatory IGRA. Next question says, does the guidance offer a recommendation on how long to wait between testing with an IGRA after TST or a borderline IGRA result? We don't have it in there in terms of the exact timing of this. So I'll give you sort of my perspective on it and what I do. I know that there's information out there about how the skin test can boost the IGRAs, and that's been shown, and it is true. The thing that we don't really know is, what does that boosting mean? Is that boosting of the IGRA increasing a result and creating a false positive result, or is it boosting in the same way a second skin test is boosting, and it's reawakening an immune response to a remote TB infection? So I don't worry, and adjust and think deeply about, exactly when should I do the IGRA. I do it in whatever time makes sense. And with OC Health, it's often doing it when the skin test is being read. So if that's the strategy that is being used, you place a skin test, you read it 2 to 3 days later. If it's positive, you draw blood for the IGRA. And I think that's fine. If the blood doesn't get drawn, though, and it has, the next opportunity to do it is in a week or a month, I just would do it whenever the next opportunity is. And same with borderline results. It's not clear that waiting any particular time, because we typically can't say what the cause of that is. I should just to clarify, the T-spot is the only IGRA that has borderline as an option. The quantiferin doesn't have a borderline. It does have an indeterminate. And indeterminates can happen for a whole variety of reasons that may be laboratory related and nothing to do with the individual. It could be the handling, the processing, other things. And so I just say, if you get a result and you need to repeat a test, repeat it in a way that makes sense and is convenient. Don't try to overthink these things, because they're just they're imperfect tests, and I've not seen good evidence that we make them more perfect by trying to precisely time when we get them. So I see a question about, so when developing the updated guidelines, were there any discussions surrounding a recommendation to do an annual S&S, that's signs and symptoms screening, in lieu of annual testing, that could be a proactive way to identify TB and could also count for that annual education? We did have some discussions around that, and a couple of things came out. One was that the signs and symptoms of tuberculosis are not very specific for tuberculosis. And so if we started asking people about coughs, even coughs more than 2 weeks, it turns out the majority of that is a post-viral infection. There are lots of people who have an acute viral respiratory infection and then afterwards have some airway reactivity and have a cough that lingers, and it has nothing to do with TB. And so again, we had a lot of conversations with the folks who have to implement this type of, these types of guidelines, the folks working in occupational health, which is not me. I work in public health tuberculosis program. And they said, yeah, we think that this would be a nightmare to try to implement, and that we would end up doing a lot of work for things that aren't TB. And that's really where the emphasis came about, making sure people understand what are TB risks and what are TB symptoms, and recognizing that ultimately the responsibility is borne by the individuals, and that's true even now with the annual or with the previous recommendations for doing annual testing. That the annual testing oftentimes missed people who in fact did have symptoms, because there were many places that relied on the tests to identify the TB for them, and they weren't doing a symptom evaluation either at all, or they weren't doing it very, very effectively. I had a personal experience with this with a person who was entering nursing school and had been having symptoms for a couple of months and had been to an urgent care twice and gotten antibiotics twice, and reported the symptoms but had a negative skin test and was told you're good, and was started an accelerated nursing school, and after a month of getting progressively worse, self-referred to National Jewish, and National Jewish was the first place here in Denver, was the first place to do an x-ray, where they found a 4-centimeter cavitary lesion. And so I think too often people have relied on the test as, again, despite efforts and education to say, that these tests are not good in active TB and shouldn't be used in people with symptoms. The reality is that's how how it happens for many places and many people, is they rely overly on the test results more than they probably should.
I do see one person typing currently, but if you have any more questions, we are going to begin to wrap things up. If you do have final questions, go ahead and please type it into the chat box.
I see a comment that says, surprising how many negative IGRAs and TSTs we see in sick persons with positive TB cultures, and that's absolutely true. The published studies of this would say that with the skin test, it's approximately 70% sensitive, so you'll miss 30% of people, and the blood tests will report anywhere from 10 to 15% of people with active culture-proven TB will be negative on their test. But I've certainly seen it enough times to know that it's just a terrible tool when trying to diagnose someone who's symptomatic, because it's just not sensitive enough, any of them. So appreciate the comment.
And I see there are 2 more people typing.
Yeah.
And I saw one participant, they asked to go back to the summary page. I'm not sure which page they were referring to, but I just went to the second one.
Oh, thanks, yeah. And are the slides available after this is done? I see someone says page 1, so I'll go back to this one. Okay.
Yes, they will be available after the presentation.
Great. And I see a follow-up comment. Yeah, it really does emphasize the importance of getting the full clinical picture and risk factors. You know, that was really part of the thinking and reasoning behind the individual risk assessment. And there are challenges depending on where someone works in healthcare and what occupational health providers feel they can ask of people. And so that was, again, why, at least with the example that we included, we designed it in a way that says, okay, here's a list of things that might change someone's risk. You know, just yes or no. Do you have any of these things that might affect how we need to interpret your tests? So other institutions, I'll say, have said, no, we're comfortable and we feel we can ask more specifically of people what their risks are related to that. So we're trying hard to be respectful of the variance among providers working in different states and under different regulations and those sorts of things. So. I see a comment, it was important to include the individual risk assessment because you need to know that when interpreting. Absolutely. And that's how we sold them on it, to be honest with the occupational health providers. Originally, when we suggested the risk assessment, we're immediately, nope, we can't ask them anything about information that might be outside of their work or personal health information. If it's not directly relevant to them performing their work, we could be seen as biased in some way, the way we convinced them was saying, well, in fact, you actually need to know that if you're going to interpret the test. If you're going to interpret the skin test or the blood test, you need to have some knowledge about that individual's risk. And then from there, we were able to move forward and include that as part of the updated guideline. See someone typing again. I know we're kind of in the final minutes. And so do nonprofits who travel to countries where TB is prevalent fall under a group that receives education about TB testing afterwards? I've traveled with some, and this has never been brought up or mentioned. Yeah, I don't know what the governing bodies or kind of certifying organizations, if any, are for nonprofits. So, obviously, healthcare organizations in the U.S. fall under Joint Commission, and then also occupational health and safety regulations and oversight. And so they have to there's an auditing process that happens, and they have to meet certain criteria. And I don't have any idea if or who does that for nonprofits that travel out of the U.S. So I mean that's where it would fall if there's not, if there are no requirements related to health of the people who are working or volunteering as part of those nonprofits, then the answer is, if no one's looking, then it would be on them to have been educated that this is an important thing for them to offer or to do for the people that are working for them.
So it looks like we have no more questions.